Well, good evening. Thank you all for joining us. This is the uh, webinar on new technology for occipital cervical fixation, presented to you by the Cervical Spine Research Society. I'm very pleased to co-moderate this with Dr. John Heller. A couple reminders. We do have the 52nd annual meeting of the CSRS coming up this December in Chicago. Abstracts are currently being accepted for another few weeks until April 24th. So we encourage everyone, if you have any research to submit, we would love to see it at the 52nd annual meeting. We also want to remind people that the Clinical Spine Surgery Journal is the official journal of the Cervical Spine Research Society. We'd encourage you to submit any papers focused on cervical spine to the Cervical Spine Surgery for possible inclusion in the upcoming issues. We're also with the CSRS becoming involved with social media, so we encourage you to follow us on the various formats, whether it's in LinkedIn, Instagram, X, or Facebook, and those are all the various identifications of CSRS on those societies. So please give us a follow so we can keep you up to date on any other upcoming events with CSRS. And then, as I mentioned, CSRS has a YouTube channel. This is a repository of presentations put on either at CSRS, the instructional course, or webinars like this. There's a growing amount of information there, so please give it a look and subscribe to the CSRS YouTube channel. So tonight, this is just our agenda for the evening. So Dr. Heller and I will lead off. Then we'll have Dr. Heller will do a review on anatomy. I will talk about how I do it for occipital cervical using both freehand and Fluoro-assisted. And then we're really pleased to have Ilyas Aleem from University of Michigan to talk about how he does it with navigation assistance. And we're especially proud to have Dr. Nick Theodore from Johns Hopkins, one of the fathers of robotic spine surgery, give us his take on how he does it using robot assistance. And then we'll finish up with some case presentations. We have one from Dr. Heller, and if time permits, I have one as well. And we'll all the panelists will be there for a live discussion. So to lead off, we're going to turn it over to Dr. Heller for a review of the anatomy and history of fixation.
Good evening. Thank you for joining us. Hope the next hour or so will be of interest to everybody. I'm going to get things started by giving you a sense of the evolution of the techniques and the technologies that we have available to us today. And then my colleagues are going to take it from there and advocate their preferred method of how to do this. So without any further ado, there was a time when dinosaurs roamed the earth. Before there were CT scanners and before there were MRIs, folks were doing posterior cervical fusions. Necessity was the mother of invention. The operations were ugly, but effective, sort of. At that time, we had stainless steel monofilament wire. It was simple, it was cheap, and it was relatively effective. But everything we did was absolutely dependent on meticulous preparation of the fusion bed and how you went about applying the use of autograft bone. It's a very different landscape today, and we'll talk about that. But in the world of occipito-cervical fusions, one was basically lashing autograft to a prepared bed between the occiput and whatever region of the cervical spine you were trying to fuse to. Then you usually applied a halo and hoped that things worked out well. With time, people became a little bit more creative about how you lashed things to the skull and the cervical spine. Rigidity was imparted by things like contoured threaded Steinmann pins, which were made on the fly, and eventually there were some purpose-built implants that might be useful in these circumstances, trying to put necks back together again. Here, a Ransford loop was designed for this purpose. It was a step forward. It was a lot better than tying in a rib graft or an iliac crest, but it had limited vertical and torsional stability, and fixation points were problematic. Not all of these things worked out so well. You can imagine what the stress riser would be if you bent a threaded Steinmann pin. They would break from time to time, and heaven forbid that they would migrate into the posterior fossa. So along came the controversy of plates and screws. Rods and modular things would have to wait a good while. This was controversial enough, and we were basically borrowing bits and parts from the small fragment sets to try to see if we could adapt them to the purpose. The challenge was deficiency of posterior elements, either by trauma, by surgical removal, by hypoplasia or poor bone quality. One way or another, wire wasn't working out so well all of the time. So along come plates and screws. The good news for surgeons and patients at the time was that in the late 1980s, we had entered an era of quantitative osteology, where scholars were looking at the size and shape of all the different aspects of the bones between the skull and the upper thoracic spine. That then allowed companies to task engineers with designing things to solve the problems that were facing us in the operating room. We learned that each bone had its own unique opportunities for purchase, whether it's the atlas, axis, occiput, the subaxial vertebra from 3 to 6, or the cervicothoracic junction. You'll hear more about the occiput from Neill with his presentation, but suffice it to say, numerous studies pointed to the benefits of the bone on the midline keel of the occipital region, as opposed to the very thin bone off the midline. Brad Currier and other scholars gave us a much better understanding of the potential for fixation at C1. He drew our attention not only to the vertebral arteries, but also the internal carotid arteries and some of the other more obvious dangers to be navigated. We learned that it was possible to do better than the traditional ways of posterior C1-2 fusions, whether it was the galley technique, Rogers, the Halifax clamp. They were fairly good at getting a fusion to fuse. They tended to fuse C1-2 in hyperextension, which we eventually learned wasn't such a great thing to do to people. But once we had the ability to grab a hold of C1 with a screw, things started to change. To be sure, one had to navigate under the posterior arch, past the C2 nerve root, had to deal with the venous sinuses around the C2 nerve root, but understanding anatomy made it possible to do that. Long before this, actually, in the early 1970s, Barber published a technique of C1-2 fusions where he used bilateral transarticular screws to cross the joint and graft the joint. That would require a bilateral exposure. These are images given to me by Tom Whitesides. He was doing this sort of surgery back in the 70s and 80s before any of what we're talking about came along. As for the axis, a number of studies within a handful of years helped people understand the dimensions and the potential for the pars, the pedicle, and the lamina. We understood about the size and location of the vertebral artery and what to watch for in preoperative planning. This gave us an opportunity to start marrying techniques and grabbing a hold of one thing or the other. You could put a transarticular screw in, or you could have a pars screw that then connected to an articular mass screw, which would be a whole lot more straightforward than the bilateral Barber technique. And then what we had was the Goyle-Harms technique for C1-2 fusions. Prior to that, Fritz Moggerl had described the transarticular screw method, which was fairly straightforward. You didn't have to deal with the C2 nerve roots or the veins, but you did have to be very careful and thoughtful about the size and location of the vertebral arteries. But both are very promising techniques. then if you found yourself in a situation where neither the pars nor the pedicle were suited to fixation, the lamina provides an opportunity as well. And statistically, it turns out that if you have an ill-suited pars region, most of the time you have an ill-suited pedicle region as well. But here's an example of a technique where the bilateral translaminar screws works out just fine. And then lastly, just to underscore the importance of preoperative planning, I'll show you this example of a situation with an aberrant right-sided vertebral artery at C2, but with normal anatomy on the left side. By looking at how the anatomy is set up, you can then cobble together a collection of these techniques and come up with a successful fixation, bone grafting, and healed fusion. Here, a combination of a transarticular technique on one side and the articular mass screw with a translaminar screw on the other side. So with that, I'll say thank you, and I'll turn over the microphone.
Well, I thought this was an amazing webinar. I really appreciate the working with John, and I really appreciate the input from Dr. Theodore from Johns Hopkins and Dr. Aleem from University of Michigan, looking at these new technologies. I think they are bringing extra tools to the field and making our surgeries better. So, John, unless you have anything different, I'd just like to thank everyone for participation and a wonderful webinar.
Yeah, thanks. It's like we had a good crowd, and hopefully everybody enjoyed it.
Yeah, thank you for putting together, Neill.
And Maria, thank you for cobbling all this together. Close it out. Have a good night, everyone.
Thanks.
Yeah, thank you, everybody.